Today's webinar is on nursing home staffing. A lot to cover today. A little bit about the coalition before I get started on that. We are a nonprofit, nonpartisan organization, and we're entirely dedicated to improving care and quality of life for people who live in nursing homes and assisted living. And we carry out our mission in a few ways. One, we do a lot of data analysis, policy analysis, and systems advocacy. Based upon that, we also publish those data in what we hope are as usable and user-friendly files as possible, and that's really going to be part of the focus of today's program. More and more over the last dozen years or so, we've focused a lot of our work on educating residents and their families, long-term care ombudsman with whom we've long partnered, of course, and other stakeholders, especially those who work with residents and families, attorneys, Alzheimer's associations, and other agencies. And we're also the proud home of 2 local long-term care ombudsman programs. Our website is www.nursinghome411.org. All of our resources are there, and they're all free to use and share, as well as prior, which I should say, including prior webinars. So this is what I'm going to talk about today. One, I'm going to provide a background on the federal law and the standards for nursing homes, just to kind of give us a setting for our discussion and for exploring some of the data on nursing home staffing. And then we'll do that next. We're going to look at the data, and I'm going to demonstrate how to find information on the staffing levels for a specific facility or for those in your state or community in a way that I hope will be as useful to you as possible. Then I'm going to provide a few insights into the data and how the data support improving staffing levels in order to improve care and quality of life and program integrity in nursing homes. And then lastly, I'm going to talk about a few other resources on our website. So a little bit of background. And I mentioned this before, those of you who attended my previous programs. I always like to start with the nursing home reform law. The law passed in 1987, and it requires every nursing home that participates in Medicaid and or Medicare to meet or exceed federal standards of care. And virtually every nursing home in the country, not all of them, but virtually all of them, participate in Medicaid and or Medicare. All the facilities that we ever talk about, that we report on our website, all the data, of course, relate to facilities that are participating, in the Medicare and or Medicare programs, generally both. So the law is really important because it sets the basis for all of the standards in the country. Now, states can have additional requirements, but no state can have less requirements. And the federal requirements are actually quite robust and comprehensive. So that tends to be the focus of our work here at LTCCC and what I encourage people to look at as well. So the law to me is really special in that it focuses on individualized patient-centered care. And what that means, as I note here in the next bullet, is that the rules require that the law requires that every nursing home resident is provided the care and the quality of life services that they need to attain and maintain their highest practicable physical, emotional, and psychosocial well-being. What does that mean? I know it's kind of a mouthful. It does not mean highest practical. Highest practicable means what the individual is able to attain and achieve if he or she is given the services that they need to achieve them. Highest practical, on the other hand, would be, say, the nursing home says that, oh, this is how much money we have, or this is how much staff we have, this is how much money we have to allocate towards staff, so this is what we have to make do, and you're going to get the services that we can provide in accordance with our staffing levels. I don't want to confuse it. That's too often the reality of life in a nursing home, but that's not what the rules call for. The rules call for highest practicable, meaning based upon what the individual can do, wants to do, and would be able to do with services. So for instance, if a resident is able to go to the bathroom with some help walking to the bathroom, then he or she should be getting those services that help to go to the bathroom. They should not be placed in a diaper because there's not enough staff to take them to the bathroom. I know, of course, that these are difficult, challenging issues. That's why we're here. That's why we're all here to talk about it and to advocate for it. But that is, essentially that every nursing home is supposed to be resident-centered and focused on meeting the understanding, and meeting the individual needs of the residents. Importantly, as I note here towards the end, is that the law lays out specific resident rights, including the right to good care, but in addition, the right to good quality of life, maximizing resident choice, resident dignity, and resident autonomy. And then lastly, sufficient staffing, which is really the heart of what we're going to be talking about today, has been required since the very beginning. The law was passed in 1987, and the regulations came out in 1991. They've been modified here and there over the years. They were changed substantially during the Obama administration, but essentially all the requirements that we talk about and we talk about today, including sufficient staffing, have been in place now for over 30 years. I'm going to talk about some of the, just a few of the requirements, because I really want to get to talking about how you can use the information, use the data effectively. But for instance, this comes from our fact sheet on requirements for nursing home care staff and administration. And as you'll note here on the left-hand side, it has some of the excerpts from the federal code about what those requirements are. And I'm not going to read them all, but the first paragraph, paragraph 1 in purple, the facility must have sufficient nursing home staff, with the appropriate competencies and skill sets to provide nursing and related services to assure resident safety and retain or maintain the highest practicable physical, mental, and psychosocial well-being of each resident as determined by their assessment and individual plans of care. And then next, sufficient staffing levels. The facility must, not may, not if it feels like it, not if it has the budget, must provide services by sufficient numbers of each of the following types of personnel on a 24-hour basis to provide nursing care to all residents in accordance with their resident care plans. That includes licensed nurses, RNs, LPNs or LVNs, and other nursing personnel, including but not limited to certified nurse aides. Another example I wanted to give was related to non-nursing staffing. And this was the focus of the study that I mentioned earlier that was just published in the Journal of the American Geriatric Society about a week ago. And this is on the role of medical directors in nursing homes. And this, again, as to all of our fact sheets, comes from the Code of the Federal Regulations, which we try to put into language that is meaningful and usable for residents, families, and those who work with them, including, of course, providers, so that they understand what residents' rights are and help their residents to implement them. So the medical director has to be a physician, and they are responsible for implementing resident care policies and ensuring the appropriate coordination of medical care in the facility. I'm not going to go into too deeply. We have a lot of materials, including, of course, this fact sheet, which you're free to download and use from our website. But there are really important, it's a very important role, And what our study found was that 36% of nursing homes reported no medical director staffing time whatsoever. And that is obviously very, very concerning, because the medical director is really the individual who is responsible for overseeing the medical care that is provided in the facility, making sure that it's safe, making sure that it's in accordance with professional standards of practice, ensuring that there are protocols in place throughout the facility, ensuring that the facility are participating in the facility's quality improvement programs, administration, etc. So really important. So the federal rules, of course, have requirements for these and other staffing categories. And that includes, of course, beyond the nursing, beyond the medical director, activity staff, social work staff, administration staff, pharmacy staff, etc. And we have information, we have fact sheets as well as a new, pretty user-friendly report on non-nursing staffing, and those are available on our website. What I thought was really important to mention as I was thinking about today's program is that the requirements for staff are obviously really important. The ones we just talked to, that they are professional, that they are participating in and knowledgeable about professional standards of care and are implementing those in the lives of the residents in their facilities. But really, and this gets back to what I was talking about earlier about the nursing home reform law, is at the heart of the law and the heart of the rules is the requirements for resident care. So we have the requirements for staff, who they need to be, what their skill sets need to be. But really, what's most important to me as an advocate and as a family member of a nursing home resident right now is that what is supposed to be happening for my resident? What is supposed to be happening for residents in nursing homes? So again, the services have to be sufficient, meaning enough staff with the appropriate competencies, other materials or other resources, et cetera, whatever the facility needs. When they take in a resident, they are promising and they're being paid to provide the services necessary to ensure that every resident is able to attain and maintain their highest practicable physical, emotional, and psychosocial well-being, depending upon who they are, where they are, and what their goals are. And this includes having enough staff with the appropriate training and competencies to provide good dementia care. These are just some examples. Help with bathing and toileting in a timely manner. Not too often I'm hearing now bathing every couple of weeks, sometimes not even bathing for over a month or many months. Toileting. I mean, we've heard for years, unfortunately, that too many facilities just don't provide appropriate toileting for residents. They have to provide activities that are meaningful to residents, including those with dementia. And again, all of these things get to what I noted in bullet one. For each, they have to be individualized and they have to be sufficient to assure that the resident is able to maintain their highest practicable well-being. So activities for a resident with dementia, for instance, putting them in front of a TV with a ball game or with an old Western movie, et cetera, that is probably not going to be an appropriate activity for them. That will lead to boredom. It could lead to someone becoming agitated, especially if the TV is loud or noisy, et cetera. So the activities have to be appropriate, and that's really important, frankly. Medication that is accurate and provided on time. Too often we hear medication errors. We hear over-medication, of course, especially with psychotropic drugs. Therapy to meet every resident's care goals. Therapy doesn't end when a resident's Medicare stays in. Every single resident is entitled to therapy, but we know that far too often residents who come in for short-term rehab, they don't get the therapy that they need, and especially for residents who are there for long-term care, their ability to access therapy is far too often precluded by the facility. I'm not going to delve into it too much, but I wanted to at least provide some information and discussion of the new federal minimum staffing standards that went into, well, they were finalized a few months ago now. And number 3 here, the facility assessment went into effect, I think it was August 10th, so just about a month ago. But there's essentially 3 components to the staffing standard. One, it requires that nursing homes have 24-hour day, 7-day a week registered nurses on duty, in the building, excuse me. 2, that they provide a minimum overall nurse staffing of 3.48 hours per resident per day, including at least 0.55 hours of RN time and 2.45 hours of CNA time. So again, 24-hour nurses, and then 3.48 hours per resident per day of overall nurse time. And then lastly, as I mentioned before, facilities are required to conduct substantive assessments on an as-needed basis to ensure sufficient resources and staffing to meet their residents' needs. And importantly, as I note here in orange, these standards do not supplant a facility's longstanding requirement to provide sufficient staffing. All the things that we've been talking about up to now, those are still in place. So if a facility should, if a facility's residents really need more than 3.48 hours a resident of staff time per resident day, then facilities still have to require it. This was really set up kind of as a baseline because we haven't had good enforcement or accountability for providing sufficient staffing over the years, meeting residents, providing a resident with the services that they need to attain and maintain their highest practicable well-being. So this is really, the purpose of this rule at this point is to really lift the bottom dwellers in the nursing home world to elevate their staffing. I'm not going to get into this a lot, but I just want to provide this. And again, this PowerPoint will be on our website, and we have more information on the new rule itself on our website. But there are a number of significant exemptions to having to provide minimum standards. And CMS has said that they expect that 20 or 25% of nursing homes will be in a situation where they'll be exempted from that low minimum standard, to be honest. So that's very concerning to us. There's also delayed implementation. So as I mentioned earlier, the requirement to do the facility assessment went into place a month ago, but the requirements for 24-hour nursing for meeting 3.48 hours per resident day of nurse staffing, those won't go into place for a couple of years, if not longer. But I want to talk just a little bit about the facility assessment, because I think that there's some meaningful parts of this for us as consumers and as family members and ombudsmen and those working with them and advocates, of course, is that one, nursing homes have been required for many, many, many years to undertake a facility assessment. And these are just some of the requirements that have existed for quite some time. Essentially, the federal government has long expected, just as any company or organization would do, to be assessing the extent to which it is meeting its goals and meeting its expectations. And if it's not meeting its goals and expectations, to be taking steps to address any challenges or issues in that regard. What the new federal assessment requirements did is that they added some context and some criteria to this. So here they know, and as I note as I highlight here, we are further modifying the requirements to ensure that facilities have an efficient process for consistently assessing and documenting the necessary resources and staff that the facility requires to provide ongoing care for its population that is based on the specific needs of its residents. So again, the point here is that we're getting back to what we talked about. What does the nursing reform law say? What do the rules that implement that reform law say? They really get to exactly this. So what the federal government is doing is saying, okay, we want to make sure that this is what you were doing. That because the inspectors are there every year or so now, even far less, with constraints on the inspection systems across the country. We want to make sure that the facilities are doing this and have really an active duty to be doing this. So this also requires not just that this goes on, but CMS, the Centers for Medicare and Medicaid Services, lays out who is supposed to be doing this. So this requires the active participation of the nursing home's leadership and management, including the administrator, the governing body, such as the board, et cetera, the medical director, director of nursing, and direct care staff. In addition, as I note here in the highlight, did I include that in the highlight? No, I apologize, Adrian. I think it was the first page. Sorry, it also requires, as I note here in the last sentence, the facility must also solicit and consider input received from residents, resident representatives, and family members. And we think that that's really essential. We have some information on that up on our website, and it's something upon which we're going to focus because I think it's really important. I mean, the facilities need to hear from residents and their families and representatives about what is going on, because virtually all the complaints that I've heard over the 20 plus years that I've been at the coalition, that I've read about in journals, in news articles, et cetera, go back to staffing. Either there was insufficient staffing or the staff were not trained appropriately to provide the care and services that residents need. So it's a really important factor that this is a robust facility assessment, and that includes the input from residents and families about what is going on for their residents and on the floor, on the ground, I should say, for facilities. And lastly, I'm sorry, as I highlighted here, it's important to note that if the facility assessment indicates that more staffing is needed than that in the federal rule, the numerical requirements in the federal rule, the 3.48, then the facility must comply with that determination to satisfy its requirement for sufficient staffing. So in short, if the facility is monitoring what's going on, it's using all its resources, all of its human resources from the administration and management to the medical director to senior nursing staff to nursing staff that are providing direct care to residents and their families, and they are supposed to be bringing all this together to identify how much staff is needed to provide appropriate care to residents. And that includes, care if there's an emergency. That's been a long requirement. If you're in a flood zone, if you're in a fire zone, if you're in a tornado or hurricane zone, for ensuring safety and appropriate care for residents under those conditions, as well as on a day-to-day basis. So that is, this is really powerful if it is implemented in an effective manner, and that's what we want to see happen. Before we move on from the federal rules, I just want to mention that the federal lobby organizations, the American Healthcare Association, and joined by Leading Age, the two largest lobby associations for the nursing home industry in the country, have sued the federal government to stop this rule. And then in addition to that, more recently, the U.S. Texas Attorney General also sued the federal government to stop the rule. And as I note here at the bottom, given the Supreme Court's recent rulings, we are concerned and think that it's likely that the industry will prevail in these lawsuits. But importantly, the lawsuits target those numerical standards, 3.48 and the 24-hour day, 7 days a week RN. They do not target the assessment requirement. So that assessment requirement could live even if the provider industry is successful in its lawsuit. So now we're going to explore some of the data. And this, I think, gets to the heart of it. How do we address some of the issues we've talked about? I've talked about essentially a lot of what the promise of the reform law, the promise of the rules, the promise of the new rule in terms of the facility assessment, et cetera, what they promise to achieve. But we're here and we know, unfortunately, that far too often those promises are not kept. And far too many residents suffer in facilities where there is not enough staff and where they don't get the care that they need. They're not treated with dignity. There's too much over-medication, inappropriate medication, too many residents that are forced to sit in a diaper for hours, sometimes even days on end, residents that go without showering, who live in a very demeaning, degrading, and unhealthy environment, far too many. So the point of the data are really twofold. One is we want to look at how people can identify the staffing data for their nursing homes and those in their community and those in their state. And this could be used to advocate within a facility, or they can be used to make better, more informed decisions about choosing a facility, or they can be used for systemic advocacy to say, okay, this is what is going on in facilities in, say, our county or our state. And this is, too many of these facilities may not be meeting the basic requirements or the basic needs of their residents based upon what the data show. So just a little background here. I mean, numerous studies over the years have shown that there's very strong correlation between nurse staffing levels and quality of care and safety in facilities. There have been a number of studies, especially I would say over the past 10 to 15 years, that have focused specifically on registered nurse RN staffing. And they found that that relationship is particularly strong for RNs, even though RNs don't provide a lot of hands-on, direct care, they supervise care. They're quite often the only professional in the building who has the ability to assess residents, the ability to really oversee and manage medications, et cetera. So the role of the RN is incredibly important. Now, a 2001 landmark federal study of nursing home staffing found essentially that nursing homes need to have at least 4.1 hours per resident day, HPRD is how we call it, hours per resident day, of total nurse staffing time just to provide sufficient clinical care, 4.1 hours per day. Again, that was in 2001. And that 0.75 of those hours should be by an RN at a minimum. These are, again, minimums. And again, they only looked at clinical care. They did not include the time necessary to meet requirements around resident dignity or psychosocial well-being. They didn't look at requirements it needs to implement effective infection control protocols, something, of course, that we're hyper aware of since the COVID pandemic. And then there was a more recent study, federal study, I should say, that found that there is, in fact, no upper limit to the benefits of higher staffing, that the more staffing a facility has, the better the care is, the better the safety is, the better the services are for residents. And then I just want to mention here, because this is really important. I mean, we're a consumer organization and we're talking about residents here, but staffing is critical. And we want people to have a good job quality, to be appropriately paid, and to have a safe job as well. And sufficient staffing benefits both residents and care staff in that way. Being a nursing home caregiver is one of the most dangerous jobs in the country. And that, we see that over and over again in federal statistics. And that is because far too often, there's not enough staff. And so the staff have to take shortcuts. Too often we hear of problems that injuries that resulted for both residents and staff when one staff person does a two-person lift for an individual. That's just one example. But medication errors occur more when there is short staffing. Of course, residents don't get bathed on time. They don't get to go to the dining room on time. They don't get appropriate services, et cetera, when there's not enough staff. And so that puts a strain, of course, on both the residents and the staff. I also want to mention we've been doing a lot of work in this area over the past year and a half, that all staffing matters. As I mentioned before about the medical director, that the medical director, for example, plays a really essential role in overshoring the quality and the safety of the clinical care provided in the facility. We've always focused, and the country and policymakers have tended to focus on nursing staff time, and of course, nursing staff time is absolutely critical. But the non-care staff have a really important role to play. Also, actually, many important roles to play. So I laid out just essentially who we're talking about here. On the left-hand side, you can see we have RNs, we have LPNs or LVNs, and we have certified nurse aides, the CNAs, provide about 90% of what's called bedside care. And then we have non-nurse staff, and those include, of course, the administrator, the medical director, the pharmacist. Now, the pharmacist, under the federal rules, must review every single resident's chart and the prescriptions and the drugs that they're getting, the medications that they're getting at least once a month. Dietary services are incredibly important for residents. Social workers, of course, occupational physical therapists, activity staff, and other. So these are essentially the data that we look at, and we're going to talk a little bit about today. There are other data, also other non-nurse staffing, that we don't include in our data sets. All of our data, by the way, come directly from the federal database. And what we do, as you'll see, is we just really average them out for every quarter when they come out, and we put them in searchable files so that you could use them and the public can use them as easily as possible. This is what our page looks like. This is the latest staffing page. It's for the first quarter of 2024. And as you can see, every time we do a quarterly report, we provide some information. You can see on the upper right-hand side what the average total nurse staffing, HPRD, is. In U.S. nursing homes, it's now 3.68 hours per resident day. So that is well above the federal minimum requirement of 3.48. The average facility is providing much more than that, but obviously that's much less than the 4.1 hours that CMS identified about 23 years ago now. We also include the total RN HPRD. That's about 0.6 hours, again, below the 0.75. And these are just averages. So half the facilities approximately are below and half are above. And you can see that here on the, I don't know if you can see my cursor, but percent of providers who are equal to or above 4.1 hours of HPRD is 26% of nursing homes are doing that. So essentially 1 out of 4 nursing homes is meeting or exceeding that federal number that was identified over 20 years ago as the minimum necessary to meet residents' clinical needs. So the industry now has been arguing that, 3.48 hours isn't possible. We just can't meet these standards. We don't get enough money. We don't, we can't hire more staff, et cetera. But in fact, over 25% of nursing homes do. And these data, I've been looking at them since 2017 when they were made public every single quarter. And it's been about the same even through COVID. About 25% or so of nursing homes meet or exceed the 4.1 hours per resident day. It can be done, but unfortunately, because those rules that we talked about earlier are not very well enforced, it's entirely voluntary. We want to make sure that it's enforced. So the residents in 75%, the other facilities are also accessing the care and services that they need and for which we pay. And then as I note here in the large arrow, you can see these are searchable files. So if you go to our website anytime, you'll see the latest staffing data from the federal government. And again, what we do is we put them in searchable files. When the federal government comes out with the files, which nursing homes report after they report their staffing data to the federal government, the federal government reports it. And we always provide a link to it, by the way, in these files to the underlying data, so you can find it yourself, is that they report it for every single nursing home that's in compliance with these reporting requirements, for every single nursing home, for every single day of the quarter, January 1st, January 2nd, January 3rd, et cetera, for every one of the staffing categories that we just talked about before. For each one of these, plus in addition, as I know on the side, whether the staff was contract or an employee, et cetera. So there's well over 1 million lines of data. What we do in these files, which you can download from our website, is we essentially average them out for the quarter. So instead of seeing what happened one day after the next, is you see what the facility was providing on average. And these are, again, on the right-hand side, the averages as well. So I'm going to stop sharing this for a moment, and I'm going to go to our open one of the Excel files so you can see the staffing data. So if you click on one of the files I just showed, this is what you would get. Let me see if I can close out some of my Zoom files. There you go. So you see it looks pretty big. And even though we've tried to make it easy, it still is, I understand, pretty complicated. But it can be fairly easy, I think, to use. So I just made it a little bit bigger. And you can see you can filter by states here. And there's a drop-down menu, so you can select the state. What we have here is a list of all facilities in the country.
Richard?
Yes.
Richard, hi, sorry to interrupt. I'm not seeing
oh, thank you very much. Let me stop sharing, and I'm going to share my screen. Sorry about that. And thank you.
No worries, thanks.
Okay. Can you see it now?
Yes.
Great, thank you. Okay, so I'm sorry, I apologize for that. So this is the nurse staffing for the first quarter of 2024. Just if you had clicked on the first box on the on the PowerPoint or on the website, you would have downloaded this. And so this provides information for every single nursing home. We have here the state, we have next the provider name, the name of the nursing home, what city they're in, what county they're in, and then we have information on what is going on in the facility for that quarter. So we have the average number of residents, their total nurse staffing per resident day, their total nurse care staffing per resident day, so excluding administrative nursing staff, their total RN staffing per day, both total RN and the care staff RN, again, excluding administrative nursing. So you can see, say you were in Alabama and you were looking at this facility, the Eastview Rehabilitation Healthcare Center, you can see their MDS, their average number of people, their nurse staffing that I just mentioned, their RN, their LPN is over here, their total nurse aid hours per day, per resident day, and then their total contract hours as well. This facility uses 0. And then we also provide the provider number, which is their official government number, in case you want to use these data elsewhere, but also to make sure that we are triple checking and that there's good integrity in the data we have. So I want to take you, so one, you see what the different data are provided. Again, the total nurse staffing, the staff that are assigned to provide care, who's actually providing care in that facility, and then the specific categories, the RN, the LPN or LVN, and the CNA. But let's also go, I'm just going to go to our state, New York. I click on that, I only get New York facilities. And so I can just, I can pull this out, I can look at what's going on in New York, I can look at New York averages, etc. But say I was, I'm an ombudsman and I was interested in what is going on in a certain county. And I'm going to pick Bronx County because Bronx County is where I was born. So let me just do it again. So you can see there's an arrow here at each column. I just click on the arrow by county name, I deselect, select all, and I select the Bronx. And now all the facilities I have are in the Bronx. These are all the Bronx facilities. So I can see how many residents they have. I could see their total nurse staffing hours per resident day. And if I click on, again, that little button, I can actually sort it by ascending or descending. So I'm sorting it by descending, meaning I'm going from highest total nurse staffing to lowest. So if I was looking for a nursing home and I lived in the Bronx, or if I was a long-term care ombudsman and I was looking to assign staff in the Bronx or looking to see what facilities I might be interested into focusing on, or say I was an attorney who was advising a family about placement, etc. I could look here and I could see, well, Beth Abraham Center for Rehabilitation and Nursing, number 1, has total nurse staffing 3.94, total nurse staffing, of 3.94 hours per resident day. It's the highest, and then it goes down from there. And you can see Manhattanville Healthcare Center is the lowest. It has only 2.41 hours per resident day of total nurse staffing time. So that makes it, I think, really easy to use and see. And also, I know if I'm, say that I don't want to, searching 15,000 nursing homes or so would be just impossible by name. Or, even searching within a state can be daunting. New York has only 600 facilities, but some states have 7, 8, over 1,000 facilities, for instance, in California. I can go to my city or I can go to the county, and then I could search for my facility name. So here, Workman Circle Multi-Care Center is one such facility, and I've highlighted it here. And then I can look and see, well, what's going on in Workman Circle? Well, they have a total nurse staffing, I just made it bigger, of 3.25 hours per resident day. That's, that's well below the 4.1. It's even well below the 3.48. So if I was a member of a family council, if I was a member of a resident council, if I was an advocacy organization, an ombudsman program, or other advocacy organization in the area, I would be concerned and curious as to what is going on with the staffing there. And then we could do the same thing for RN staffing. So if I just move on to RN staffing here, and I could again sort it by descending. So I could see this is the RN staffing. And if you can see, oops, sorry, just let me make it a little bit bigger. Let me move this over. I'm not doing that very successfully. Sorry about that. Okay. But you can see that there is an arrow by the column that you chose to do the selection. So that's a little arrow. It's going from high to low. So here, Fieldstone Lodge Care Center has the highest RN staffing. Again, remember how RN staffing is especially important. Whereas if you scroll down, Throgs Neck Extended Care Facility has only 0.26 RN staff. So I'd be really concerned, frankly, if I was a resident there, or if I was working with residents there, or if I was recommending a facility placement in the Bronx, I'd be very concerned about these facilities that have such low RN staffing time. Who's overseeing care? Who's supervising care? Who's supervising medication management? Those things would be, would again be of concern to me. So those are, just, highlighting and looking into the nursing staff time. Now, another of the categories that we have were the non-nurse staffing. So I'm going to look at that. And again, similar format, same thing. We could filter by state. We could filter by CMS region, especially if you're doing national advocacy. This is really important. There are 10 CMS regions, and we've done studies on this. There are significant differences in the performances of nursing homes between states and also even between regions. So that could be meaningful as well. But let's just break it down here for someone who is looking at a state or a local facility. So let's look at, let's choose Connecticut. You know what? I'll choose one on the other side of the country. Let's choose North Dakota. So these are North Dakota facilities. And again, the same thing. I could go by my city, and I could select just the facilities in a certain city or the facilities in a certain county. And then again, we have the MDS census, but here you can see the hours the administrator is in the building on average for the quarter, and then the minutes per resident day of administrative time. And then we have the hours for the medical director, hours for the pharmacist. So look, this facility, Bethany on 42nd, and actually Bethany and University, I'm wondering if they may have the same owner, they have 0 pharmacy hours on average for the quarter. So how is that facility undertaking the requirement that a pharmacist is reviewing the records and the medication records of every single resident on a monthly basis? Maybe they have someone doing that outside, or maybe they don't. But that is, that is a question that we could ask as an ombudsman, as a family or resident, as an advocate, especially if we see that or we have concerns about the medication in that facility. Here are the hours of the dietitian we provide. Also, so you can see, again, this comes directly from the federal data. The only thing that we have done is average it out for the quarter. This is the hours of the PA and the NP, the nurse practitioner, and then of the different therapy staff. So it's speech language, social worker, activity staff, OT, occupational therapy staff, and PT, physical therapy staff, etc. Feeding assistant staff, it goes on. So you can find out what is going on. Now, like if I had a resident with or loved one with dementia, and I was going to place them in a facility, I'm going to just switch to a state that has maybe a little bit larger and has more residents, so we can look and see by a specific county, because North Dakota being small is not going to have a lot of facilities in a specific county. So I'm in Georgia now, and I am just going to select, I don't have a map in front of me, but I'm going to select Calhoun, Camden, and Candler counties, just for the heck of it. But I could obviously, look and see what counties I was interested in, if I was a local ombudsman person or focused on that. And I could see now what facilities are in those counties. Not a lot for this choice. But you can also then see, okay, who has the most physical therapy time? If I'm going to a nursing home and I am looking for physical therapy, especially if I'm going in short term or if I'm going in long term and I have needs, for instance, if I need help walking or I want to learn, you need help relearning how to walk, etc., then I want to know how many physical therapy, how much physical therapist time there is. Excuse me. So here you can see I said ranked it from low to high, and you could see Orchard Health and Rehab has the lowest. Calhoun Nursing Home has more than twice as much. So again, not everyone could be an expert. I'm not expecting that a lot of families or individuals who are looking to place a resident will go there themselves, but this can be useful for people who are helping them, but also useful for people who are advocating, whether it be within their state or with their county, with their legislators who are representatives, or excuse me, who represent these different counties, et cetera, to say, hey, you represent Pulaski County, and the nursing home here has really low therapy staff time. What is going on there? Maybe really low, other services time as well, activity staff, et cetera. So again, using this information in a way that is informative. And then the last thing I wanted to show is weekend staffing. Weekend staffing is really important because residents have the same needs 7 days a week. The residents' needs don't decrease on Christmas, on July 4th, on Saturday or Sunday, etc. However, too often we know that facilities staffing goes down on holidays, and certainly too often goes down on weekends. So what we did here is we have it's kind of the same setup, and I'm going to go to, let's say, Massachusetts and look at Massachusetts staffing. And I'm just looking at Massachusetts, and I'm looking at, these are all the names of the providers. Right now, they're in alphabetical order. These are the city, town, the county or parish, because some states have parish. This gives you a little bit more information. It gives you the ownership type. But here again, average number of residents per day, their overall rating, their different ratings, a little bit different data file. But if you go down towards the end, we see this is reported staffing hours per day, excuse me. And then we see the staff turnover over here, total staff turnover. So you can see big differences. This facility, Aberjona Rehab and Nursing, has 18.9% staff turnover, whereas the one above it, Abbott Skilled, has 54.3% turnover. Wow. I mean, unfortunately, that's pretty typical in the nursing home world, but the turnover is very, very high. Registered nurse turnover, and then we have more on the staffing. But here is the nurse aide staffing hours per weekend total nursing staff, excuse me, per resident day over here. So we can see what is going on with between the daytime, between the weekday and the weekend staffing. So useful information. We have some other information here too, whether or not the facility has a resident and family council, whether they have an abuse icon, whether they have a special focus facility. I don't want to digress too much. There are just a lot of resources that we have, but here I wanted to focus on the weekend staffing and the turnover, which are two important indicators of quality and safety for nursing homes. I'm going to go back to the PowerPoint. So all this information is available right here on this page. The nurse staff, non-nurse staff, we have summary data, and then the turnover and weekend file is right over here. We have an alert with the key findings for every quarter, and then we have an interactive map that you can look and see what's going on in your state. And as you can see, we provide the state rankings and information here towards the bottom. That's what we did. And then just a few data insights I want to share before we end. So, we talk about sufficient staffing. As I mentioned before, there have been numerous studies over the years showing that there are strong correlations between overall nurse staffing and higher quality of care, and especially between RN staffing and overall quality of care. There have not been studies, there really haven't been studies on non-nurse staffing, although we think that those roles are critical. As I mentioned, we just came out with what we believe is the first ever study that I mentioned before that looked at medical director time. But we are certainly going to be doing more work in this area because, as you can see, those non-care staff, the pharmacist, the medical director, OT and PT and activity staff are really critical. What is going on in facilities that have little or no of those staff categories there? But here I just want to provide a few data points from our database. So this looked at, does the number of substantiated complaints vary by facilities that meet a 4.1 hour per day staffing standard? And what the data show is that nursing homes that don't have 4.1 or higher HBRD have 86% higher substantiated complaints. This is a little bit hard to see, I apologize. This looked at the relationship between RN staffing levels and substantiated complaints. And as you can see, as RN staffing, the bottom, the bottom line, RN staffing levels per resident per day, as that went up, the number of substantiated complaints went down pretty significantly. This looked at for-profit, government-owned, and nonprofit. What is the impact of chain ownership on nursing homes? And what the data show are that nursing homes that are part of a chain have 24% lower RN staffing. So again, something for us to be thinking about. What is going on with chains? This is we can also do state files as well. So this looks just at New Jersey. Infection control, and it finds that, that infection control violations go down as nurse staffing go up. I'll try to make it just a little bit bigger so you can see. So this is the number of citations for infection control inspections. That number goes down as the reported RN LPN in 8 hours per resident day goes up. A little bit smaller. This is the relationship between weekend nurse staffing levels and star rating. So what we found was that the average star rating, the average weekend staffing for a 1-star facility was 2.87 hours per resident day. The average weekend staffing for a 5-star facility was 3.90 hours per resident day. A huge, huge difference, over an hour of time. That is a lot. I wanted to briefly mention, I know we're coming towards the end, and this will be in the PowerPoint slides, obviously, as well, that we'll share, is that nursing homes are claiming now that they can't hire more staff because they can't find the staff, or they don't get enough money to hire more staff. And both of these claims are really not based upon anything that is any independent and verifiable data. And as I noted before, the typical nursing home has over 50% annual turnover. Better nursing homes, in my opinion, would have obviously lower turnover, but some of the poor nursing homes would have much higher turnover. And having 100% turnover a year is not that uncommon, meaning that you have this constant influx of people coming in and out. And how does that impact your ability to hire people? Well, it's not just that you can't, it's not, the point isn't that you can't hire them. The point is really you're not taking the steps to keep them. And so that's the issue. If you were just able to retain your staff, then you would be able to improve your staffing. And then, the fact is that there are more and more facilities that operate for profit. And the easiest way to cut down on your expenses and increase your profits is to decrease staffing, and also always have staffing that are just in the first or second year of working the facility, not having staff that have been there for 10 or 15 or 20 years, because those staff become more expensive, they have more vacation time, etc. So I'm not going to go through all this because I know that we're close to the end of our time. This is just some information in terms of Medicaid rates going up persistently over the years, Medicare funding going up, and having, nursing homes having double-digit margins, profit margins on Medicare for over 20 years. And then I'm just going to quickly mention we have some other data. We have provider data files on our website, and that includes information on each nursing home, who their ownership is, whether they have an abuse icon, whether they've changed ownership, what their ratings are, what their citations and fines are, whether they are owned by a chain owner, what CMS calls an affiliated entity. So really useful information if you're looking at what's going on at facilities in your community, et cetera. And of course, we also have antipsychotic drugging rates. We've been publishing this for quite some time now. We color code it so you can see if your facility is lighter colored, it has lower antipsychotic drugging, rather than darker colored red is higher psychotic drugging rates. And then these are just some of the resources on our website. Our next program will be October 22nd at 1 p.m. I am really excited. It's a community response to improving nursing home care. We have two really terrific speakers who have done some amazing work in Pasadena in California, and really excited to be having that. And I think that's it. We have just a few minutes, but I could stay on for a little bit longer if that's okay, if people have questions to ask.
Thanks so much, Richard. Yeah, we have a lot of really good questions in the chat, so I'll just start with the first one. The first one is from Gary Bennett. He said, in New York, is DOH now enforcing state and federal staffing standards? What sanctions is DOH now typically imposing?
That's a good question. So New York and most states now have a minimum staffing standard, and the New York's is pretty new. New Jersey's is also pretty new. There's very little information on the extent to which in New York that they have been enforcing that. I understand that letters have gone out to providers about their providers who have not met the state's staffing standard, but I personally am not aware of any enforcement actions that have been taken. And I just please a reminder for everyone that the federal staffing standards, again, the numerical requirements of 3.48 hours per resident day, the 24/7 RN has not yet gone into effect and will not for a couple of years. So nobody is enforcing.
Thanks. The next question I think is referring to the federal staffing standard. It says, how do you know if a facility is in a workforce shortage area?
That's a good question. I think that's the CMS put out a memo on that, but I think that remains to be seen. As I said, it will really depend upon what happens when and if that rule is actually implemented. As I said, I'm a little bit cynical about whether that rule will survive the challenge in courts by the provider industry. But if it does, we'll have to see. And as I mentioned, CMS is anticipating that I think about 25% of facilities will receive a waiver, but we don't know exactly how that's going to be implemented yet. They will be using the federal definition of like rural facility, et cetera, for those purposes.
Thanks. The next question is from Debbie Johnson. It sounds like her mom is in a memory care facility with specialty training, and she wants to know if large quantity of falls equate to short staffing. She said her mother is in the facility and there's been 4 falls with significant injury within a month.
So yeah, I think falls is one of the really key indicators to quality of care and to safety, and of course to having sufficient staffing with the appropriate competencies. Thanks.
Kimberly Hodges wants to know, what tips would you share for state policymakers?
I think that's one I could probably share. There are a lot of things that they could look at, but I think really key is looking to see what is going on with the staffing in your nursing home, what is going on with enforcement to some extent. Just to take a step back, the information that we have on nursing homes is fairly limited. We have the staffing information that we've talked about today, that is self-reported by nursing homes. It is supposed to be based upon payroll records and auditable by the government. In addition, there's the results of the state inspections. And then the other information that we have is what's called the MDS, the minimum data set. CMS calls them quality measures. And I tend not to pay much attention to the quality measures because they're self-reported for the most part. Not all of them, but most of them are self-reported and unaudited. And then the inspection results, we've done a number of studies, the Government Accountability Office and others have studied this as well, that have found that the states tend not to do a very good job identifying when there is a problem. So long way of saying is that you have these three types of data. Really, the staffing is the most valuable, I think, the most in that it's the most accurate. It's not perfect by any means, but and it is subject to fraud, but it is the most accurate. And I think that looking at staffing and looking at what's going on, especially with RN staffing, especially with the medical director time, overall staffing, of course, looking at turnover, that would be a good way to get insights. And I think also looking at what's going on with the chains, what CMS calls affiliated entities, because we see, as I mentioned, a couple of times, more and more for-profit companies are coming into the sector. I mean, even though the nursing homes claim they don't get enough money to say hire more staff or provide better food, et cetera, this is a major profit center for real estate investment trusts, other big companies, and small companies as well. And so there's not a lot of accountability, and looking to see, okay, what's going on with the performance. Some of the highlights that I mentioned before are some some things that they could be looking at as well. It's a great question.
Yeah. The next one is from George Russell. He says, are the 26.2 homes that meet or exceed the 4.1 HPRD primarily nonprofits?
That's a good question. I didn't look at that. I assume that it is. The not-for-profits tend to have higher staffing than the for-profits do.
Yeah. And then the next question, I don't know how many more you want to take, but the next question is from Debbie Johnson. If the facility isn't showing up that we're looking for in the staffing data, why would that be?
So if the facility does not show up in the staffing data, it means that they were not in compliance with federal reporting requirements for staffing, or that they had some other issue in which CMS was suppressing the data for them. So that is a problem. Now, just worth mentioning that facilities also have to report their staff on duty within the facility at all times. That's not as strong a requirement as this is, because this information has to be based upon payroll records. But if the facility was not there, I would be questioning, what is going on? Why aren't your data there? And when will it be back? And you could also look at past quarters too to see. I mean, it's available on our website to see if they had information there before.
The next two questions are both related to the PBJ data. So the one is, how is the PBJ data collected, and is it accurate, or do nursing homes inflate the data, and where can the daily data be found?
Those are good questions. And I think we'll just take one more after that. This one, that's okay. So the PBJ data, PBJ stands for payroll-based journal. So it's based upon, as I mentioned just a moment ago, it's based upon the payroll records of the facility. And that was supposed to increase the integrity of reporting. This was part of the 2010 Affordable Care Act, required nursing homes to be reporting their staffing on a daily basis to the federal government. And so those data are available on the CMS database. If you go to our website and if you download any one of those files, you can see every file has notes. It said, a summary and notes. And if you go to the notes tab, you can find a link as to the underlying data, which is useful too. So as I said, we average it out over the quarter to provide people with a more simplified and overall picture of what their facility is providing. But as I noted in the discussion of weekend versus weekday, there can be really big variations. And if you're working in an individual facility, that could be really interesting and useful to look at. So you can go back to that data base and look at it for an individual facility and see for a specific quarter what the staffing was for all 90 days. And of course, you can add multiple quarters together. You can look at it the whole year, etc. But there is just a last note. There is a lag time. So we're talking about the first quarter of 2024 now. So as you can see, we're in September. I forget when it comes out, but essentially the facilities, when the next one will come out, excuse me. But the facilities at the end of the quarter, they have time to compile their data and to report it to CMS, and then CMS, cleans it up and makes sure that there does some integrity checks before it publishes, presents it to the public in that data file, And then we take about a week or two generally to, we triple check it to make sure what we're providing is accurate and to provide it to the public. So there is some lag time.
Thanks. The last question here is actually about a point you made during your presentation. It just says, can you repeat the data point on nursing homes that don't meet the 4.1 threshold? Complaints are 80% higher.
Yeah, I think, no, the substantiated complaints, I'm just going to look back really quickly, were, I think it was 84%.
86, I think.
Yes, you're right. So nursing homes that do not have 4.1 or greater hours per resident day have 86% higher rate of substantiated complaints. So not just complaints, but complaints that have actually been substantiated by their state agency.
Thanks.
Yeah, thank you.
And the slides will be available on our website as well as the presentation or the recording of the presentation for today.
Thank you. Thanks everyone for joining us. Thanks so much, Haley.
Thanks all. Have a nice day.
Bye-bye now.